It's 8 o'clock and welcome to today's episode of Marvelous Medicine. We are going to be going back to the basics and the speaker is Professor Srinivas. The session will be moderated by Dr.Anita Suryanarayan. She's the Vice President and Head of Quality Assurance for South SBU with Metropolis Lab and also the Senior Consultant at High Tech Diagnostics. Dr. Anita did her MBBS and MD Pathology from University of Mumbai and is trained in immunohematology. She's a member of various professional organizations and her the speaker, as I mentioned, will be Professor C.N.Srinivas. He's the Vice President Technical, HLA and TI Lab, SRL Diagnostics, and the Head of Department of Laboratory Medicine at Fortis Vadapalani Hospitals, Chennai. Professor Srinivas did his MBBS from Bangalore University, MD Pathology from University of Madras, and his DPNB Pathology as well. He's also certified in laboratory management and leadership. Professor Srinivas has 50 national and 40 international publications. He has delivered lectures and conducted workshops and conferences across the globe. He spearheaded the automation of urine analysis in India and has mentored many students in laboratory medicine, immunology, and total quality management. Thank you, Professor Srinivas and Dr. Anita, for readily accepting to participate in Marvelous Medicine. Dr. Anita, your comments on Professor Srinivas.
There's no better teacher. There's no better speaker, honestly speaking, who can talk on basics the way Dr. Srinivas can. And he is the one person who has defined laboratory medicine as laboratory medicine. For everyone else, laboratory medicine was either pathology or biochemistry and all that, but no one ever took laboratory medicine as a whole. And Dr. Srinivas is one of the few people, one of the only people who I know defined it. And he started what we call as a lab professional day, which is a day for everyone, you know. So whether you're a technical person, you're a technician and all that, anyone who's participating in a lab is a lab professional. And thanks to him, we do have this celebration across. And I'm just looking forward to this feast. So shall we just get on with it? And I leave Dr. Srinivas.
Yeah. Thanks so much, Dr. Vidya and Dr. Radhakrishna for introducing to this marvelous medicine and also giving an opportunity for us to showcase our laboratory medicine. Just give me a moment. I'll just get onto the share screen. Hope the screen is visible to all.
Yes, sir.
Okay. So shall I start now?
Yes, sir.
Okay. So now we have with us three basic simpletons, which I always love it because these three basic tests gives a lot of information for the clinicians as well as the laboratory group who can actually collaborate in a multiple exponential way to give a great information to the healthcare system itself. So I'll take about 40 minutes to go through simple things about the complete blood count, the usefulness of the total protein, and the urine analysis itself. So to begin with, we'll just take up with the complete blood count itself. Now, we all know that the term CBC, which actually refers to that of what we call as a complete blood count, is very useful in diagnosis of various types of disorders, starting from hematological disorders to the metabolic disorders to that of the systemic disorders itself. The disorders can also be systematically grouped and it can be picked up itself. And the laboratory hematology will actually, in fact, guide the clinicians for the further workup for the cases which has been referred, either for diagnosis, either for therapeutics, or it may be for a preventive health checkup itself. So we all know that the complete blood count evolves around three cells, that is the RBCs, the WBCs, and the platelets, and the counts of this. In addition, we also get the hemoglobin value and the RBC indices, which are MCV, MCHC, and MCH. And I have put here a new parameter, which you people may be knowing, or you might be now thinking that, okay, it's just the machine which has been given this number. That's the red cell distribution width. But the confinement of these parameters are only for the clinicians. But there are a lot of things in the complete blood count which one can analyze from the newer hematology machines itself. The evolution of this count started from the simple Salis hemoglobinometer and the counting chambers. From there, we got on to the evolution of the 3-part and the 5-part. And from there, we see what is required for the peripheral smear analysis. And we were able to give a defined pattern of the turnaround time for the complete blood count and the peripheral smear itself. So the journey started with the manual counting to that of the 3 to 5 differentials itself. From 5 differentials, what do you mean by 3-part and what do you mean by 5-part? 3-part refers to the differentials, what the machines is giving. The machines are able to give in a 3-part, 3 fractions: granulocytes, lymphocytes, and monocytes. But when we come to the 5-part differential, you get lymphocytes, monocytes, neutrophils, eosinophils, basophils. So we are satisfied or not, we don't know. But what happens, the craving for the needs became demanding. So today the 5-part differentials has become now, to get on to the extended differentials, we get around more than 120 parameters. But clinically proven, we have 6 to 21. But if you have a good pally-pally relationship with the laboratory people, they'll be able to solve a lot of problems what you would be facing in the clinical practice parameters which are available in the hematology analyzer and give you more precise, accurate diagnosis with great clinical sensitivity itself. So from the limited differential diagnosis, today we have got extended differential diagnosis which are possible from the hematology analyzers itself. What do you mean by extended differentials? Today, when we are talking about the sepsis, people would like to love to know what are the counts of the immature fractions, what are the counts of the nucleated red blood cells itself. To go back to the nucleated red blood cells, presence of the nucleated red blood cells in the peripheral system indicates that the marrow is having a hyperactivity itself. What do you mean by the presence of the immature fraction? The immature fraction refers to the granulocytes starting from promyelocytes, myelocytes, metamyelocyte band forms in the circulation itself. So I was talking to you about the infection. When you are talking about with the infection, and if you would like to know roughly whether this patient has got into bacteremia or sepsis, the fractions which are important are the immature fraction and the nucleated red blood cell itself. From the hematology analyzers, which are extended differentials, we will be able to tell you what is the count of the NRBCs itself. Suppose the NRBC count in an adult is more than 3%. It indicates that the person is having hyperplastic marrow, probably with an increase in an immature fraction of more than 2%, we can arrive to a conclusion of 60% that this may be probably an inflammation which is happening in his body. Then correlate with the C-reactive protein and deduce that, yes, this person is falling into the group of bacteremia and sepsis itself. Next is the hematopoietic progenitor cell count itself. If we have a hematology analyzer to give us what is the count of the hematopoietic progenitor cells, we will be definitely be happy, because the hematopoietic progenitor cells, when they are present, we categorically say that it may be either presence of the blast cells, or it could be an induced therapeutic levels of the HPC level count increased, so that we can harvest this hematopoietic stem cells for the autologous blood transfusion itself. But what is the basic importance of this hematopoietic progenitor cells if we are going to use the extended differentials? By use of the flow cytometric evaluation by the automated hematology analyzer, we will be able to say whether the hematopoietic progenitor cell is a blast cell or it is a non-blast cells. We mean to say that it could be something to do with that of immature cells which are having a morphology which cannot categorically be defined as a blast cells. It could be even an MDS MPN group itself. So the utility of the hematopoietic progenitor cells will be with that of the oncologist as well as the bone marrow therapeutic group itself. The presence of the immature fraction and the nucleated RBC is very important to all of us, because when we are working with the group of general medicine group, as well as that of the infectious disease group and the ICU. This parameters of the NRBCs and the imaging fraction becomes very critical. In addition to that of the differential count, I have put here retic. Now, reticulocyte count is also very important nowadays because reticulocyte count is an early marker or early detection of the anemias itself. Most importantly is the iron deficiencies as well as that of the vitamin B12 deficiencies itself. Now, coming to the utility of the CBC, we all start with the basics. So let us start with the basics. How will I able to categorically say this patient is anemic? Depending upon the hemoglobin percentage as well as the hematocrit. So if the hemoglobin is less than 12 and the hematocrit is less than 38, the anemia could be because of the decreased production like hypoproliferation, where the reticulocyte count is less than 2%. That means the reticulocyte count being normal, there is hyperproliferative stage in the bone marrow where it is producing a hemoglobin of less than 12. These groups belong to the nutritional deficiencies predominantly. Coming to that of increased destruction. When there is an increased destruction, the reticulocyte count will also be more than 2%. So only I told that the reticulocyte count is very, very important indicator to understand the marrow status itself. So when we come to know whether it is a hypoproliferative or it is increased destruction, the workup can be very much easy. And with the help of the laboratorian, we can proceed for the investigations itself. Now, coming to the most important parameter other than the hemoglobin is the MCV itself. I really do not know how much of our own group, that is the medical fraternity group, including the laboratorian, biochemists, microbiologists, clinicians, look add-on value for the MCV itself. The red cell volume is measured by the MCV itself. And with the help of the red cell distribution width, we can get up to 90% of the diagnosis with the CBC itself to categorically say what sort of anemia we are dealing with. Let us now take with the MCV as a parameter alone for the classification of the anemia. For the classification of the anemia, MCV can be divided into normocytic, where the values will be between 80 to 100 femtoliters. So if the values of the MCVs and the hemoglobin are good enough, the normocytic group will fall between 80 to 100 femtoliter. In Indian population, this can be altered depending upon the places where you are working, because when you do the reference range verification, you will come to know that the normocytic group falls between 70 to 90 femtoliters in Indian group itself. Now coming to the microcytosis. So microcytic anemia, when the value is less than 70 femtoliters or less than 80 femtoliters, and macrocytic when it is more than 100 femtoliters itself. So by help of the MCV, one can classify what type of cells this group is having, whether microcytosis, normocytosis, or macrocytosis itself. Coming to the next important parameters is the red cell distribution width. The red cell distribution width ranges between 14 to 16 normally. I'll tell you there are two ways of looking into this, but remember that the red cell distribution width has got a very important factor for classification of the anemias itself. The red cell distribution width gives us the average size of the microcytic or the macrocytic group itself. Suppose we have got normal RDW, that means it is a normal population of the cells. That is, we call this as an isomorphic cells. Suppose the RDW is high, it indicates that there is anisopoikilocytosis or it has got double population itself. That means to say that when the RDW is high, it indicates clearly that the red cells are having different shapes and sizes in the peripheral blood. It could give an outlook whether it could be a microcytosis or a macrocytosis itself. Now the algebra starts actually. Now, I always love this tabular column because it gives us what sort of microcytic hypochromic anemia the case given will be presenting itself. Let us take now low MCV first. When there are low MCV, these are the differential diagnoses you have got. You have thalassemia, iron deficiency anemia, then you have got microhemolytic anemias and anemia of chronic disease itself. Can RDW help? Yes. If the RDW is normal with the low MCV, good amount of hemoglobin of 12, but the RBC is more than 5 million, then you think of thalassemia minor. That means the RDW is normal, MCV is low. Now, suppose the RDW is high with low MCV, definitely it belongs to the category of iron deficiency itself. So with the help of the RDW and MCV, we can come to some sort of 90% conclusion that what sort of anemia the patient is having itself. Now let us take this case 1, case 2, case 3, which we have got from the printout from the auto analyzer itself. Let us see this circle component here, and I also take you here. In the case 1, if you see, the hemoglobin is 3.9. Now let's come to MCV. MCV is 49. When you come to that of the RDW, I told you there are two parameters here. One is SD, one is CV. Now, both are important for the clinical groups, but most of the time we only give the SD because that's the one which is better referenced. Now, there is a controversy between which one I have to use. SD refers to the standard deviation, CV refers to the coefficient of variation itself. But for me, I feel that the RDW coefficient of variation is sensitive in iron deficiency anemia, where the RDW will be high. Here, if you look, the MCV is 49, low, RDW more than 16, it is high. So this is a case of iron deficiency anemia. Let us come to case 2 here. The MCV is 70, RDW is 16. This is probably could be a thal. Let us take case 3. Hemoglobin MCV is 63, low, whereas RDW is 17, which is borderline, which may require a peripheral smear analysis itself. So what I would like to illustrate with these three cases is that by the help of the MCV and the RDW, we can get an information about the type of the anemias itself. Fortunately, the accrediting bodies in India as well as internationally have made a mandate that all the CBC counts has to be released with the RDW to the clinician, and the clinician should be made aware of what is the importance of the RDW so that we can pick up nutritional anemias as well as thalassemia itself. So that's about the utility of the MCV RDW in microcytic anemias. Coming to the macrocytic anemias, beautifully, the American Society of Clinical Pathology classifies the macrocytic anemias into two groups, megaloblastic, non-megaloblastic. Why they have brought this distinction? A megaloblastic anemia with a deficiency of vitamin B12 and folate will 99% have an MCV of more than 105. If your autoanalyzer gives a value of 105 and you try to estimate the vitamin B12 and folate, 99% of the time you find that there is a deficiency of the vitamin B12 or folate itself. But remember that in India, the vitamin B12 and the folate deficiencies overlap with the iron deficiencies, and hence we will be missing out the characteristics MCV of more than 100 at all. So cases where you have got dual nutritional deficiencies about the iron deficiency and the vitamin B12, the iron deficiency will be showing you an MCV of less than 70. So we should be very careful when we are looking into a case of microcytic anemias as well as macrocytic anemias. A word of caution, I'm telling this because in India we see more of iron deficiency, but we may be missing vitamin B12 and folate deficiencies in them. So whenever you have anemias, you better recommend for B12, folate, as well as the iron. And if the lab is doing active vitamin B12, it's wonderful. Now coming to the non-megaloblastic macrocytic anemias, in this group, the MCV will be between 90 to 105. So the American Society of Clinical Pathologists made this distinction because a meta-analysis showed that more than 105, most of the time it is B12 folic acid deficiency, less than 105, more than 90, femtoliters. These may be the causes. The most important being the liver disease and the alcoholism, hypothyroidism, bone marrow infiltration by tuberculosis, or it would be by that of the metastatic group, drugs like antidepressants, immunosuppressants, as well as we have anticonvulsants, cytotoxic drugs, chemotherapeutic drug may also lead on to the non-megaloblastic macrocytic anemias. Now, the macrocytic anemias, where you have got a value of more than 100 or 110, vitamin B12 is very, very important. Now, this is how you get the macrocytosis, but remember that this evidenced only when there is a very bad deficiency of the vitamin B12. But if you want early detection of the vitamin B12, I think we should go with the active vitamin B12 status itself. Now, let us come now to the RDW utility in the macrocytic anemia. As I told you, the MCV and the RDW utility in the microcytic anemia, where we found out that when the RDW is high, it is iron deficiency, and the RDW is normal, it is beta thal. In macrocytic anemias also, RDW helps us. If the RDW is high, MCV of more than 100, it is most probably a megaloblastic anemia itself. So in a megaloblastic anemia, we find that the RDW is high as well as the MCV is high. Suppose MCV is high, but RDW is normal, most of the time it will be non-megaloblastic group, that is liver, cases, cirrhosis, or something to do with the post-transplant case or immunosuppressants. This is the tabular column just to reiterate that high MCV, RDW being normal, you might have a liver disease or a myelodysplastic syndrome. High MCV and high RDW is vitamin B12 and folic acid deficiencies. So we found out that by the utility of the MCV and the RDW, we are getting more information about what type of anemias this clinical case might be having it. Now, the next most important parameter and most neglected parameter is the MCHC itself. Most of the MCHCs are between 33 to 37. If there is a case where you have got a raised MCHC of more than 37, these are the things which we have to remember to rule out. Whether we have got a cold agglutination, interference by highly turbid plasma like lipemia, increased hemolysis, bilirubin is interfering there, low sodium, especially in the ICU cases, as well as that of oncology, abnormal osmolality in the neurological cases, trauma cases, and lastly is the spherocytosis. Why I have put spherocytosis is that in most of the spherocytosis, they have additional deficiency of the nutritional anemias, and in India will not be able to see the MCHC of more than 37 in spherocytosis, but the above causes, agglutination, lipemia, hemolysis, low sodium, abnormal osmolality, definitely you will be seeing it in the clinical practice itself. So whenever you have got a high MCHC, the technical staff itself will come with a saying that the case is having a high MCHC, it could be something this, and we have to evaluate and communicate it same to that of the clinical group itself. Now, other than that of the detection of the anemias, how else the CBCs can be helpful? The scatter plot, what we call these as the colorful diagrams over here, can help an unsuspected case or a visitor all of a sudden to the laboratory and to the clinician. When we're working with pyrexia of unknown origin, where you have a low platelet count of less than 1.5, if you look at the hematograms or the histograms and the scatter plots, where you have got the differential, you have got only bluish or ash coloration from this analyzer, it indicates that you have got the malarial parasite. From 2017 onwards, all the manufacturers of the hematological autoanalyzers are bringing education to that of the laboratory professional to pick up malaria by their own ways. So one of the machine vendors who we utilized shows that there is an increased amount of prevalence of malaria in this case. So accidental detection of the hemoparasites can also be obtained from the hematology analyzers if you're asking for a complete blood count. Why we are insisting for a complete blood count? Because you get a good picture. And the other important thing is that do not ask for hemoglobin TCDC itself. If a person is asking for hemoglobin TCDC, we have to tell him that it's better that they go in for a CBC completely, because it gives a value addition and cost effectivity will be there. This is the case from where we got the malaria. So the previous case shows clouding over here, and to understand the peripheral smear, I just got the falciparams in this blood smear itself. Another one case where you have got an eosinophilic wedging over here, which we call, again, it showed malarial parasites itself. So these pictures I have got from hematological analysis, which we use. But one you should understand is that depending upon your machines, it will give you a flag off. Histograms can also be giving you an alert saying that there is a malarial parasite itself. Now, in addition to that, the scatter plots gives you a lot of information too. On your left-hand side of the screen is a normal colorful WBC scatter plot from a flow cytometer. And on your right-hand side is again one of the cases from that of a flow cytometer with the same machine, where you are able to see that this is completely ash color, not able to differentiate between any of these groups itself. So these groups are telling you the magenta is lymphocyte, this is a monocyte, green color, neutrophil is blue color, eosinophil is eosinophil in color, and the basophils are tagged over here. Whereas in this, the machine is not able to see anything. So it is just going to flag you saying that I'm not able to differentiate. So it looks for the peripheral smear itself. So suppose it is a dengue or it is a lymphocytosis, again, the machine is going to give you the same. On the right-hand side, you look, the lymphocytes are there not only in down, also in the up. So when you have a flag off of a fishtail appearance of the lymphocytic curve, that is a granulocytic curve, one has to understand it could be a dengue versus that of a blast cells itself. This is again a case of chronic myelocytic leukemia. Now, in addition to that, please inquire with your laboratory whether they are able to do body fluid examination and counting by the automated machines. The same hematology machines can be utilized for automating your blood fluid automation itself. The automating the blood fluid analysis becomes very important for the CSF, availability of the services 24 hours, differentiation of the neutrophils, monocytes, and the malignant cells can be easily done. I've just got 2 slides to make us understand that how it is useful. Now, this is a same scatter plot of a machine, which you are able to see. This is from the CSF. And you look this is an abnormal CSF, where the WBC are more than 12,000 here. And you have got predominantly neutrophils as well as monocytes here. So this could be a case of septic meningitis itself. We have to correlate with the biochemistry, but this is available, and most of the hospitals are also using these platforms of automating the body fluid count itself. So that was about a simple gesture, what I took some time to tell the utility of the MCV, RDW, scatter plots of the WBC itself to help us out in day-to-day practice. They also showed you about how the hematology machines can have a role in reticulocyte count, neutrophil count, the NRBC count, as well as that of the body fluid itself. Now let us go to the second simpleton, that is the total protein from the clinical chemistry itself. Now we all know that the serum proteins are macromolecules, and there are 3 major ones in the blood: the albumin, the globulin, and the fibrinogen. Now, whenever we get a request for a total protein in the laboratory, we estimate albumin only by measuring it accurately. I mean to say, we have reagents only to measure the albumin and the total protein. Globulin is a calculated parameter. Most of the time, the post-analytical errors in the total protein estimation is that the clinicians will call that the globulin values are not right, recheck. We have to understand that the total protein is measured, albumin is measured, and total protein minus albumin, globulin is given. So there may be a calculation error in getting you the globulin. So you should make sure that the laboratory information system, the IT system, and the manual keying in has to be verified properly before we release the reports of the albumin and the globulin itself. We know that the albumin is majoritarily produced by the liver itself, except the immunoglobulin. The immunoglobulin is produced by that of the plasma cells itself. The plasma cells are having various terminologies, has got various actions. What are the actions? It could be a transport protein like albumin. It could be an acute phase reactant like C-reactive protein, defense mechanism, which helps in immunoglobulin, coagulation, which helps in that of the coagulation factors, as well as that of prothrombophilic groups itself, shed cellular proteins from that of the cells, especially the beta-2 microglobulin, as well as alpha-1 antitrypsin, oncofetal proteins, especially the alpha-fetoprotein, which we make it as a tumor marker. Now, all these proteins are either metabolized either in the kidney or in the skin, but most of the time it is manufactured in the liver itself. Now, I already spoken to you about the functions, and the most important thing about the total protein is that maintenance of the fluid distribution and the oncotic pressure itself. Now, what are the indications for the evaluation of the total protein? Now, total protein actually gives a mirror of the nutritional level of an individual. So, physiologically, it will give us a nutritional status of that patient. Pathology of any body activity like increase or decrease in the serum osmolality, gastrointestinal disorders like malabsorption, weight loss, which is happening. We do not know why the patient is losing a lot of weight. Hepatic disorders, where you have got increased bilirubin, and you have got hematological disorders, which are there, like that of anemias and leukemias, and something to do with immunological disorders, where you have got opportunistic infections and chronic kidney disease itself. Now, the analytical methods are various. We don't have to go, but we should remember that you have got biuret methods on it is done by the refractometer itself. And the most important analysis, which is usually neglected, is the electrophoresis itself. The total protein evaluation is necessary, but when you find a hypoproteinemia or a hyperproteinemia, it is advisable to do a serum protein electrophoresis itself. Now, the disorders of the protein metabolism have been capsuled here, and I can categorically say that you have two groups: hypoproteinemia, hyperproteinemia itself. Hyperproteinemia is basically because of nutritional, alcoholic, hypothyroid, cancer, malabsorption, hepatitis. Hyper is basically hyperthyroidism and plasma cell disorders itself. At this junction, I would like to mention that the plasma cell disorders are rampant in Indian population, but it is not diagnosed at the early stage because we are neglecting the serum protein electrophoresis investigation itself. So I will be just giving you some tips about how to go about with the serum protein electrophoresis and how it can be useful in day-to-day practice. Serum protein electrophoresis is performed usually to diagnose dysproteinemias, and the separation of this takes place at the alkaline pH, depending upon the net charge of the protein, isoelectric point, and the molecular weight itself. The diagnosis and monitoring of the patients with monoclonal gammopathies, chronic inflammation, protein losing syndromes can be fantastically done, not only by diagnosing, but also for the monitoring purpose itself, as well as whenever you have got an elevated ESR. Say suppose you have got 100 as an ESR, definitely you require a protein electrophoresis. You have proteinuria like that of a nephrotic syndrome. Ask for that of a serum protein electrophoresis because light chain diseases are usually picked up. Increased or decreased serum total protein concentration definitely requires serum protein electrophoresis. How does a normal serum protein electrophoresis look, and what are the fractions we get? This is a schematic diagram. I'm showing you the live next. This is an albumin, which is a high peak. Next, you have got alpha 1, alpha 2, beta 1, beta 2, and gamma. So that means Very near to the anode, you have got the albumin and the liver proteins itself. So whatever the proteins which are manufactured by the liver will be separated initially from left to right. The extreme light one will be from the lymphoid proteins, which is called as the gamma region, which is represented by that of the immunoglobulins itself. The beta region will give you an idea about C3, C4, which becomes a complement levels, very important whenever you have got lupus nephritis or autoimmune diseases. Alpha 2, whenever you have got hemolytic anemia, you'll be having an increased haptoglobulin itself. Alpha 1 trypsin. In this juncture, I would like to say that a lot of cases of bronchitis and bronchiectasis are missed out because we are not doing the serum protein electrophoresis in these cases. When we are trying to do the bronchiectasis evaluation, empyema of the lung, respiratory disorders of the lung, I would recommend that the clinician should order for a serum protein electrophoresis to rule out alpha-1 antitrypsin deficiency itself. It has been estimated that 4% of the population are usually having deficiency of alpha-1 antitrypsin itself. Now, serum protein electrophoresis is destined only to diagnose myeloma because from our undergraduation and post-graduation, we have been brainwashed to say that how will you diagnose myeloma? We say serum protein electrophoresis and we say that there's an M peak. But that is not the way, but the serum protein electrophoresis can pick up many other things. Now, it can also pick up when you have got an early phase or a late phase of acute inflammation. And this will be the, I'll just show you the pattern. So this will be the chronic inflammation where you have got the albumin here. They've got a polyclonal elevation of the gamma globins here. Next will be the chronic inflammation acute phase where you have got elevation of alpha-1, alpha-2, beta, gamma. That means all these fractions are elevated here, which indicates that the patient is having absolutely active acute chronic inflammation itself. Nephrotic syndromes where you have got depression of the globulins here like this, elevated globulins of the alpha-1 and alpha-2 itself. Next, you might get sometimes biclonal peak in the gamma region, which indicates that the patient is having a lymphoma myeloma group itself. Next, you have got classical myeloma, which I put it at the last. Why I put it at the last is that myelomas are being detected by serum protein electrophoresis, but these groups are usually missed. That's why it's very important that we understand that serum protein electrophoresis is very important, not only with respect to that of myeloma or the plasma cells, or also with the other diseases itself. This is one of the cases where you have got the peak in the beta region. Whenever you have got a peak in the beta region, we have to evaluate for the IgA group itself. Now, the last part is urine analysis itself. We have last about 10 to 12 minutes. Let's see how urine analysis can benefit our clinical practice. So I have only a request, make urine great again. Now, urine analysis, when we talk, people do ask only for albumin, sugar, and microscopy, but things have changed now. People are asking for a complete urine analysis, which is good because the lab takes care that the urine undergoes 9 to 11 strip chemical testing and an intact microscopic testing too. Now, the urine analysis is important to evaluate the functions of the kidney, which everyone knows. But it is also important that you pick up the early urinary tract infections and hematuриas and proteinuриas, which can prevent the kidney disease progression itself. Coming to the epithelial cells, if you are really in a hospital practice, working with that of a sepsis, ICU case, road traffic accident, trauma care, the renal tubular epithelial cells becomes very, very important. Crystals and casts, I feel casts are more important, and crystals like that of amino acids like tryptophan, cysteine becomes critical. Whereas casts like that of broad cast, muddy cast, as well as granular casts are very important in chronic kidney disease cases pickup. Most of the time, the urine, when it comes into the laboratory, undergoes chemical testing starting from protein, glucose, nitrates, ketones, and bilirubin leukocyte esters. Microscopically, we'll be identifying the cells, casts, crystals, bacteria, and mucus. Additionally, when you have a request, we get culture, cytology, and molecular diagnosis if you're going in for a fish for that of a therapeutic monitoring of the bladder cancer itself. The routine urine analysis has been changed from that of the manual process to that of an automation. Today, we are doing automatic chemistry examination, automated microscopic examination with imaging itself. Now, urine analysis gives predominantly two groups of information. One is one group related to the glomerular injury itself. The other group is the tubulointerstitial group. If there is an injury in the glomeruli or the blood vessels, it is reflected either as hematuria or proteinuria or both. If there is an injury in a tubulointerstitial parenchyma, you have proteinuria as well as predominantly cells, cast and crystals. Now, one of the major important thing which everyone has to understand is that after the urine has been collected, it has to reach the laboratory within 4 hours, or it gets into decayed sample and it may not be of any value. Like you have got lysis of the WBCs, lysis of that RBC, the pseudomycelia of the yeast develop very rampantly, increase in the bacterial growth, giving you a false alarm. Trichomonas loses the motility, becomes like that of the WBCs, and we might be erring on this sexually transmitted protozoa itself. So you might be requiring a turnaround time delay, recollection, redos, unnecessary treatment, because if there's a bacteria increase, you're going to say bacteria reported, culture is given, there is already a payment, antibiotic is already on course, there will be financial losses also. Now, the automated urine testing, the physical and the chemical analysis is by the strip methods, where we all use reflectance photometer or a visual measurement itself. There are some limitations in the chemical testing, which everyone have to understand. What is the limitation? Our enemy is vitamin C. People who are taking multivitamins, people who are on vitamin C are prone to give us false analytic values. That means the bilirubin, the glucose, and the nitrite will be interference. That means the evaluation of this may be negative. That means even the patient who is having blood will be giving you a negative report itself. So you should understand that the urine strips may give you a false low value or a false negative response, not only to the blood, but also to bilirubin, glucose, and nitrate in the presence of the vitamin C itself. So we should write in the test requisition form when you're sending it for the laboratory that the patient is on vitamin C or a multi-drug or a multivitamin tablet, because the clinicians may err. And when it comes to the laboratory will see that the patient is having enormous amount of RBCs in the microscopy, but the chemistry test is negative. So we have to make sure that the test request form contains details of these multi-drug vitamins itself. Now, there is a list of others, but I do not want to bore you. But remember that every ingredient may be having interference in your test strips. Now, coming to the urine sediment, which was discovered way back in 1830s in Paris, has to undergo a bit of process at the laboratory. We have to take about 10 to 15 ml of the urine, spin it, discard the remnants, and we have to see under the microscope for the presence of the cast, WBCs, acanthocytes, that is the dysmorphic RBCs, as well as the hyaline cast itself. Now, today, the flow cytometric or the image-based evaluations are available for the urine microscopic evaluation itself, which becomes very easy for every laboratory to give a beautiful report on the hematuриas, casts, and the crystals itself. So in the automatic process, we can improve the turnaround time. Personnel can be utilized in a better way, standardized process, and more objectivity you get in. You can also get information about the dysmorphic RBCs or the isomorphic RBCs or the mixed RBCs from the flow cytometric evaluation in the urine analysis itself. Now, this tabular column is very important because the American Society of Nephrologists in 2020 defined that these urinary profiles are commonest in their practice. We only know mostly about the nephritic and the nephrotic syndromes, but these groups are also there in the clinical practice. Acute tubular injury, acute interstitial nephritis, crystalline nephropathy, osmotic nephropathy. Based upon the urine analysis itself, they have classified this. These are the chemistries, what you see. And if you see, most of the time you have got proteinuria, hematuria and interstitial nephritis as a nephritic syndrome and crystalline nephropathies. And these are the hyaline cast retic cast. Retic refers to renal tubular epithelial cells, commonly seen in acute tubular injury and AKN, as well as that of the crystalline nephropathies itself. Just get two cases to understand how this works out. So on your left-hand side is the chemistry. You have got blood present in the chemistry strips 3+, proteinuria is there, leukocyte is also there. Now coming to the microscopy, on this side, you have got RBCs here, as well as renal tubular epithelial cells and pathological cast. So this is how the flow cytometric evaluation shows that this patient is having mixture of RBCs, predominantly dysmorphic mixed with that of the isomorphic. And these are the images, what you can see from the urine analyzer, which shows you the dysmorphic images. And this is the granular cast or the RBC cast. What you're seeing here are the images of the RBCs, renal tubular epithelial cells. Here will be the cast, and it has been flagged for the cast positivity. Let's see the renal biopsy. The renal biopsy shows more number of glomeruli, which are bubbling with activity. And in the high part, you can see the necrosis, lot of neutrophils over here, lot of neutrophils in the interstitium, damage to the renal tubular epithelial cells, which consistently gives you a value on IF. C3 is deposited, C1q is seen, and this was a case of acute infection-related glomerulonephritis. Why I've got you all this is that starting from the simple urine analysis, we can come to the conclusion that what kidney disease this patient might be having, nephrotic or nephritic or tubular, crystallar, what group they belong to. Next case is hematuria, where we see isomorphic RBCs. So when you get isomorphic RBCs, whenever you have got tumor or stones in the pelvic calyceal region or in the urethra or in the bladder itself. Let us see this case. This is a 56-year-old male hematuria. He presented with blood is 0.75, which is 1+, whereas the presence of the RBC is around 2,348. Now here you see a peak which says that it is an isomorphic RBC. This is a beautiful high part to show you this is an isomorphic RBC. This is the presence of the red cells. And these are the isomorphic RBCs we are seeing. Flooded with isomorphic RBCs. Here you can see a broader image here. These are the isomorphic RBCs. And the cytospin of the urine showed these atypical cells. So make sure that when you have hematuria, we do a cytospin to review the cases for atypical cells and advise cystoscopic biopsy. It shows that it is a transitional cell carcinoma. So when you have powerful P's like this, you can evolve yourself into an enhanced, enriched report for every report, every sample what you get to everybody at every time itself. So there's a need for the laboratory and the management to invest on expertise and equipment, have an envision and envisage to give a better value for all the samples, whether it is blood or urine, and in the turnaround time should be maintained so that every sample reaches a good value at the right time by engaging both the clinicians and the laboratory group itself. Thank you very much.
So,
Dr. Srinivas, over to you, Dr. Anita.
Yeah, no. If you have something to say, ma'am, please do.
Yeah, no. Over to you.
So thank you, Dr. Srinivas. As usual, this was mind-boggling, not mind, and all the things which we do miss and we need to know. And as usual, you made it so very simple, but it's not all that simple. So I know that urine examination has been something which you have been trying to promote for a very long time. I think it's the most easily collected specimen, and it is the most neglected specimen. Would you agree on that?
Absolutely, absolutely. That's why I'm telling them that everyone should give due respect to urine, and they have to do this very importantly, because otherwise we are going to miss a lot of disorders which might be actually damaging the kidney itself.
Yeah, and you mentioned the automation. and manual also. So now, what is your opinion on, see, we do automation, but we are confirming by manual all the time. So
Yeah.
what would be your take on that?
Okay, so if you have got a good verification which you have done initially for at least about 100 samples which are normal and abnormal, I think that only the isomorphic RBCs group require a cytospin to make sure that you pick up the malignant cells or a normal RBCs itself. And you require a wet mount only to pick up the renal tubular epithelial cells confirmation, because you are diagnosing a case of acute kidney injury based upon the evaluation what you did. These two are critical, Dr. Anita. So I think that these two definitely requires the most important microscopic examination. But I think if you get used to the automation, it will be like a peripheral smear where you're going to see only the cases which are positive and you can go ahead with it. The other important thing what I would like to suggest is that take a look at the epithelial cells. If the epithelial cells are more than 5 to 10 per hyper field and you have got a lot of bacteria in it, try to ignore that, because that's not a proper midstream urine collection what they have done. That is important. The other important thing which we usually neglect is the pH of the urine, which is very important. The pH of the urine decides what type of crystals we usually see in the urine. Most of the time, the pH is usually neglected, either by a dipstick method they do it, or with that of it strips what they're using it. But when you have a proper pH examination by an automated machine, which you all have, even a simple chemistry readers, then check with that of the crystals, because we might miss cysteine as well as tryptophan crystals in this urine itself. I feel that urine microscopy will be like your blood microscopy in coming days, because your review rate will come down from current maybe 50% to 20%.
I have a very simple question to ask you. Why don't we trust automation at all? Whether it is a CBC, whether it's a urine examination, everything, even if it's leukocytosis, we'll go around making smears. Is there anything, understanding is less or the training is less? What is less that we don't really go in and give the results which are there without confirming? I mean, I'm sure you're seeing that everywhere.
Absolutely, absolutely. Now, what we call as a flag review criteria is available. See, we have to go by that of the flag review criteria given by the machines. The IVD manufacturers in their kit, they usually tell that these are the flags which are being raised by the machines. When you have a flag like this, please go with that of the manual confirmation so that you will be able to get a confirmed report on this. So let us now analyze your case of leukocytosis. When you have a case of leukocytosis which has been flagged off by your by your automated machines, definitely we would like to know what sort of cells which are there. Am I missing a blast cell? Is it a leukemoid reaction? Or it is a presence of the NRBCs which are making this as a leukocytosis? We have to evaluate that. Coming to that of the platelet count, which I strongly recommend only to believe the automation rather than that of our smears.
Right.
Because we always get a question from the clinicians, it is a low platelet count, I want only the manual count. People should believe that the platelet counts are robust by the hematology analysis, and hence I always say, if you find that the platelet counts are low, there is no platelet aggregate which you can pick up on the graphs, go ahead and release the platelet count rather than doing a smear itself. When you come to that of the urine, definitely when there are flag criteria, you have to make sure that initially you prepare the sediment analysis, confirm, and then you can get the grip of what sort of flora you will be seeing in this flagged off cases, and you can release it.
Thank you very much. And also, I think everyone is aware that we can also do urine for drug, estimation for drug abuse, so that urine samples could be picked up for that also. Yeah, and they could be tested for that also. So, and the collection mode is the most important mode. And I think more emphasis would be, to place on how it's collected, how it's transported, and as soon it is done. That's where I would feel it's important. Now, you have expressed on protein so very well. Most of our reports, if you see, just go by no gamma, band seen or no evidence of myeloma seen. And today you have shown us that we have to pay attention to so many things. So would you have a specific reporting criteria which you would suggest? You have shown that, but just to make it easier for everyone to understand.
Anita, I think you are bringing up a great discussion, which I would really love it to answer to you. Now, there is a standard format of reporting this protein electrophoresis. The College of American Pathologists have brought out guidelines on reporting the monoclonal antibodies itself in the year 2020. Now, way back in 2019, the Association of the Biochemists of Australasia has brought out a very good booklet on templates for reporting the protein electrophoresis itself. It is freely available. People can download. They can keep this in their bench, and you can use this because it's a monograph which has been meticulously prepared with the templates, what you have to give and what you have to share with that of the clinicians. So these guidelines are available. You're muted, Anita.
Yeah, you explained that extremely well, and I think that's where we should be putting our remarks. Not that everybody can see that this is the ratio is okay. Those are very standard remarks, and we should give more value add for the protein electrophoresis reports, which is there. One more thing I've seen that in transplant places, the total protein is always on the lower side, where everything else may be normal. Is there any specific reason for that? Do you think?
Yes, probably this patient might be losing protein in the urine. So we have to recommend that these patients should give the urine for the evaluation because they might be having a protein leakage in their kidneys, which may be creating the hypoproteinemia. One. The second thing is that when you look at these post-transplant patients, they are on immunosuppressants. This tacrolimus, cyclosporin, sirolimus, everolimus, do have some impact on the absorption at the GIT itself. They themselves can produce the interferences in the absorption. So I think these are the probable sites where we can plug up and to understand that this may be the protein leaking group or it may be a non-protein drug interference group itself. The other most important thing is that when you have hypoproteinemias, take a look at the LDH as well as the gamma glutamyl transferase itself. A very sensitive indicator to understand that whether you have got a drug-induced hepatitis, which is causing you this manufacturing capabilities to be reduced from the liver site itself.
Yeah, thank you. That was a very interesting, remarks. Do you recommend, Dr. Srinivas, that we should, as pathologists, advise our clinicians as to how to proceed when we have seen something? Like adding some more tests or adding something, it will be benefiting. Our reports are supposed to benefit the patient. So what is your take on some doctors like it? I think there may be some consultants here. Some doctors do like if we give additional remark or we call them. And some, of course, are not really, they may not like. So how do we approach this particular, cases? Yeah.
Very, very tricky in both hospital practice as well as in standalone practice. See, what happens is that in cases like, we'll take the first scenario in the hospital-based practice. In a hospital-based practice, if you are having the patient, you can immediately call up to that of the doctor and say that, okay, doctor, this patient is having this abnormality. Can we go ahead? And you might add on with it. But coming to the standalone, it do happens that there are 50% of the clinicians who says that, doctor, you please preserve these samples. You can do the testing and this patient will be available and I'll tell them to come and bill it up and you can bill it up and you can give the release, the values. So of course, we have to communicate to the clinicians that they have to add on reflex testing to these abnormal values or altered values when you get, and we will be adding a better interaction in that way to get a trust mutually so that we can grow together to make a robust healthcare system.
Okay, there are a lot of questions which are coming, but there is one question I have always wanted to ask you. Suppose I'm a hospital and suppose I'm a lab. And how will I choose for my lab and for my, whether it's a hospital or what? which type of instrument do I go in for? There are high end, there are 3-level, there are 3-part, 5-part, extended part. So what would make me choose, which one analyzer I should go in for?
Okay, so we can categorically say that at the current era, I feel that the best one is to go for that of a 5-part differential, even in a small laboratory, because it will give you a lot of information to even pick up a myelodysplastic syndrome to MPN itself, rather than to just stick on to the 3-part itself. But you are a high volume laboratory where you are getting per day more than 300 hematological samples, whether it's a standalone or a hospital, they should go in for an extended differential analyzer where you will be able to detect NRBCs, reticulocyte count, as well as the body fluid counting itself. That's a simple strategy which I can share with.
And one last thing, yes. One last thing is, how good is reticulocyte count automation?
Okay, very nice question, because all CBCs, if they are going to be released with the reticulocyte count, I would be very, very happy, because that's the first parameter where it gets hit, where you have got anemias itself. So based upon the MCV, RDW, and the reticulocyte, I can come to a conclusion that, okay, this patient is probably having a iron deficiency or a TAL or an MDS or an MPN. So it's good, but automation in reticulocyte is fantastic, because you get not only reticulocyte count, but you also get what we call as retic hemoglobin, which will give us a value of the erythropoietin activity in the bone marrow. Very important for nephrologists, hematologists, before they inject the erythropoietin itself.
I think I'm monopolizing you totally, but I can keep on asking questions and we will keep on having a discussion. Dr. Vidya, can we just open it? Because I do see questions coming from the audience also.
Yeah, so the first question is from Anuja. She says, sir, what is the clue in MCV to differentiate between megaloblastic and non-megaloblastic anemia?
Okay, I had told in the session itself, but to reiterate, if the MCV is more than 105 femtoliters, it goes in for megaloblastic anemia. Okay, the non-megaloblastic group are the MCV where it is ranging from 90 to 105. If it is between 90 to 105, it is a non-megaloblastic. Megaloblastic is mostly more than 105 itself.
The next question is from Kavita. Dear sir, should we recheck manually protein trace or urobilinogen trace when the machine gives a report before releasing it to the patient or clinician?
Okay, so first we'll finish off urobilinogen, because the new guideline says that the strip manufacturer should not manufacture bilirubin and urobilinogen. So from next year onwards, when you're ordering, your dipsticks will not have two things. Urobilinogen will not be there, bilirubin will not be there, because urobilinogen and bilirubin was introduced for picking up of the different types of jaundice. But when you have a sensitive liver function test, this has been removed now. Coming to the manual protein trace. Now, one has to understand the kit pack insert initially. If the kit pack insert is able to pick up protein of about 20 milligram, then your strips are very good, because it is detecting the microalbuminuria itself. So we have to have a sulfosalicylic acid test initially only for the day to check up whether you have got a trace protein and it is positive. But you are using an automated machine where the protein quality has already been passed. So you can go ahead without manually checking to release the protein itself. So simple to say, if your QC has passed in your dipsticks test, I don't think that you're required to manually verify the protein itself.
Thank you, sir. Another question from Dr. Vijay David. How did malaria RBC come into the neutrophil area when RBCs are usually lysed in a WBC counting chamber?
Dr. Vijay, it's a very great question. Whenever you have got RBC, which are infected whenever you have got a malaria which has infected the RBC, the cell membrane of the RBC becomes lyse resistant. Now, the next thing is that the digestive material of the hemoglobin, which has been done by this malarial parasite, is hemazoin pigment. These are inclusions. So for all flow cytometry, it will consider this as granulocytes. or unidentified eosinophils. So it gets dumped in a neutrophil area or eosinophil area because of the size. So the size becomes bloated, cell membrane become thick, acid resistant, granules are present, so you get into the neutrophilic area itself.
So we have an anesthetist, Dr. Anshuman Mishra, in the audience. Anshuman, very often nowadays, when we go to see patients in the pre-op area, pre-op checkup, a whole host of investigations which we wanted and didn't want, or we don't know who ordered, and there are reams of papers, and sometimes we are probably the only ones who are going through all those reports. So has today's session given you any value addition as to what to do when you look, though you're not the treating physician, you're just doing a pre-op assessment for a surgery? Has this helped in any way? Anshuman, are you there? Okay, then I will. I mean, on behalf of. So Dr. Srinivas, thank you very much for clarifying many of the things which many of us learned maybe 10, 20 or 30 years ago, and things have changed so much, and there has been, though, like you said, these are the simpletons, they are basic tests, but actually their interpretation and the way the tests are done has advanced a lot. Though the test that you wrote as which I wrote as an intern in the 80s is, we may write the same test on the requisition, but actually what is happening to the sample and the amount of information that you're extracting from it and how it will help in both in diagnosis and monitoring has exploded. So thank you very much for helping us to read those reports, which many of us, just skip through. We'll see just the complete hemogram has so many parameters, but most of the time we look at just one or two and skip and run. So when COVID came, we started looking a little more at the RDW. When some other new information comes, then we look at one more parameter of that. But many times we are guilty of not actually going through all the details. And thank you so much for bringing out the importance of each and every value that the expensive automated machine that we have, which all the hospitals and labs have bought and invested. At least we should get the maximum benefit out of that. And also removing the bias of manual. So like you said, this platelet count is one of the commonest things, especially in the preoperative check. If the platelet comes low, the knee-jerk reaction for everyone, including the lab, is to say, wait, we'll do a manual count before we release the report. So I'm thank you for the information that actually the platelet counts are extremely accurate when done by the automated machine. So we will not fall into that sort of knee-jerk reaction of asking for manual counting. Radhakrishna, your comments?
And just to echo what he said, Vidya, I never understood that there's so much information in this simple test. I think from tomorrow onwards, I'll look with the special eyes at these, and I'm sure this lecture should be seen by every medical student, every clinician in the country, and I think they change the way they look at these investigations. And actually, I didn't know that there's so many advancements that are taking place in this area, that you can diagnose so many minor things so very well. And as surgeons, at least as an anesthetist, you would at least spend some time with those as surgeons. We just glance through and we never knew the nuances. I mean, thank you. It's been brought out so very well, and I wish, as Vidya says, I learned these things many years ago. I think I had to go through this video again and again to assimilate whatever messages it gives. Thank you so much.
Dr. Anita, just you brought up the point about advising additional tests. The radiologists do that routinely when they interpret a chest X-ray or a CT or anything, ultrasound. They write their findings and the provisional diagnosis, and they very clearly write that be advise CT scan to confirm or advise MRI to confirm. The pathologists do that when they do an FNAC or whatever, you know, then you say, okay, we need a biopsy to confirm, or when the biopsy comes, they do immunohistochemistry. So I think that I don't think the laboratory medicine people should hesitate at all to advise for further testing, because most of us are not kind of up to date with everything. There is a huge knowledge gap among clinicians. We have to accept that. And of course, at the same time, probably you should not get offended if they don't do the test once you recommend. But in the interest of the patient and in the interest of the science, I think there should be no hesitation. I look forward to the laboratory reports coming with a tag down that, given this thing, this is the advanced next level test that we would recommend. So
yeah, I have one question to Dr. Srinivas, if you don't mind.
Yeah.
Then is the artificial intelligence being incorporated into your machinery so that it will give, just like the ECG gives, so that we need to exercise our brain so much that it will give this is pneumonia, this is, GI-induced sepsis and so on. Do these messages come with your reports?
People are working with that. The artificial intelligence is being worked up. The investment for these are becoming an obstacle and a bottleneck for the groups which they are trying to get onto this. But there is what is called as a CDSS, which is called as a clinical decision system support, where if you see that you have got a low MCV and a high RDW, the software immediately says that you have to check in for the iron deficiencies and the serum iron profiles itself. These are available, and these have been sold also as a middleware by that of the vendors itself. So the investment cost being a bit high, people invest them with very cautiously. So they're not investing completely on this AI as the radiologies itself, because the number of the tests starts from that of 150 to 1,500 tests in the laboratory. So incorporating the entire manuals of what you are doing requires a lot of decision processes in the given system itself. That's the cost is making hindrance. Otherwise, systems are already there.
Okay, thank you.
Yeah.
There's one more information I think, Dr. CNS, we need to tell. When people are asking only for hemoglobin, or RBC, we can very well give all the other counts, because anyway, we are going to run it, and it's no use having an RBC count or a hemoglobin without knowing the indices. So how is it going to really help? So it's just for information that it's not going to charge the patient extra. He's only going to benefit, if you get what I mean. Is that right, sir? Dr. CNS?
It's right, Dr. Anita. The secret has been now given to them.
No, but since we are
no, they have to ask it. See, people have to understand that the same 60 microliter which gives you all the parameters. So it is better that they ask for a 200 rupees to 300 rupees test rather than invest individually on hemoglobin DC for 600 rupees.
Sorry, I let the secret out, but I let it out.
No, I kind of figured that out a while ago. But Dr. Srinivas, sometimes it's just laziness, because suppose we are having a patient with acute hemorrhage, or post-operatively we are following up every few hours, then I think we don't want information overload with all the parameters coming in. So we prefer to just look at the hemoglobin and decide, okay, am I going to transfuse this patient or not? But definitely, as part of diagnostic tests and all, your point is well taken. We are not, the cost is going to be the same, and the machine is going to run all the tests. So you may as well get a printout of the whole thing. So thank you for that information, Dr. Anita.
Padmapriya has got a question.
Padmapriya, please feel free to unmute and speak. Padmapriya?
Put a question.
Yeah. Thank you very much. I think it was very informative. Sorry, sir, I had to join halfway through. I'm an neonatologist, so obviously, I'm interested in the amount of blood that has been drawn for the labs. So I just wanted to know how popular in India. Abroad, I know they use a lot of micromethods. In India, how common or how popular are the micromethods where, we're talking about 60 microliters. So sometimes we have to, that is very difficult to draw in a very small preemie, because we deal with 600, 700 grams, 800-gram babies. So I just want to know, are across India at least, are most labs familiar with micro methods, or is it very difficult, or cost is a constraint? I just want to know the technicalities, please.
Dr. Padmapriya, I can just share that there are some what are called as microtainers, which are available for pediatric collections itself. These have been very much designed for the aseptic collections from that of the pediatric group, starting from the neonates, which are what you're saying about 600 to 700 grams, where the samples are really drawn this and we are getting this. Now, the current hematology machines as well as the urine analyzers are having what is called as a manual opt. So when you go for a manual opt with the low volume, I have to feed this into the machine and we can still get you the values. So even if I have about 1 microliter of the urine, I can go with that of the manual mode, put it in the small aliquot what the instrument manufacturer has given, and I can give you the value. That's for the CBCs or for that of the urine analyzers itself, which can be done. It's available in India.
Yeah, no, what I'm saying is the regular machines which they have, I mean, basically in a multi-speciality hospital, it's mostly adult oriented. So sometimes they tell us, most often the lab does it. I have no problem with that. But, occasionally they sometimes say the sample is insufficient, send another sample and all that. So is there a way that you can work around it, or is it something, people have to understand that, like you said, this, manual opt method, is it available in most of the machines?
Manual opt method is available even from the 3-part differential analyzers. Even if you are in a tier 2, tier 3, and you are having a 3-part, you will be able to have that manual option, ma'am. You can ask the vendor to help out to understand manual methods in this with the low counts itself, the low volumes. You can run that. All manufacturers are having.
Okay. Yeah. Thank you very much.
That is really precious information for us, Dr. Srinivas, that even the regular machines probably have that option. So that thank you for that wonderful question, Padmapriya. Otherwise, we wouldn't have learned that today. So there is one more question, and Amaya, would you like to ask your question? So Amaya wants to know what is the significance of urine for dysmorphic red cells. I presume that is what is written on the request. If somebody writes a request saying urine for dysmorphic red cells, what does it mean? Or maybe I'm interpreting her question wrong, Dr. Srinivas.
No, ma'am. She has asked the right question. They're asking what is the significance of the dysmorphic urine or dysmorphic red cells in the urine. Now, when we have hematuria, we have to classify what type of RBCs we are seeing. If it is a dysmorphic RBCs, which means that it is a broken RBCs, the damage is at the glomerular level. So when you have a glomerular damage, glomerulonephritis, what they call, then you see a lot of dysmorphic RBCs. Suppose you have got isomorphic RBCs, intact RBCs, then it is basically a free flow of the blood which is happening because of the micro leakage in the cases like tumors of the pelvic ileal system, ureters, bladders, urethra. So that's the difference between the dysmorphic as well as the isomorphic and the importance.
Amaya, I hope you got the answer to your question. If anyone has any other questions, please feel free to raise your hand or unmute and speak. We have a few more minutes available. Yes, Deepa. Deepa, your hand is raised. You can unmute yourself and speak.
Yeah, I just want to know for synovial fluid analysis of serum body fluids, do we use the CBC analyzer, or do we need to change it to another mode for analyzing the total count, or do we use the?
So in any of the automated 5-part differentials, we have to demand whether the vendor has got a body fluid option mode in that machine. If they have got a body fluid mode in that machine, whenever you get any fluid, serous fluids or the CSF or the synovial fluid, the mode has to be changed to that of the body fluid mode. Do a background check so that the chambers where the counting is happening is totally 0. Then feed the sample so that you get an accurate count on the fluid itself.
Okay. Yeah. Thank you so much.
Thank you, doctor.
Vidya, you're muted, unmute.
Dr. Srinivas, you have anything that you could not include in your talk, but
No, madam, I think we have brought out most of the things, and I'm happy that the discussion was very interesting and interactive, where we were able to discuss so many things which we would be opting for, and it was very good.
Just one more thing I'd like to bring to people. If we see cases like dengue or something, you'll find the platelet count one day is very low. And suddenly the platelet counts rise. Many times we have been told that no, your counts are not correct. Yesterday it was maybe 30,000, 40,000 today. So they rise at a remarkable rate after the infection. Is there any reason for that? It's just an observation. I don't know how far it's true.
Anita, the initial first part of the question I was not able to hear because you had muted it. Can you just repeat the question?
So no, what I meant to say is that in cases like dengue or where the counts are suppressed, you do have counts which are lower on the other side, and 1 or 2 days when you do the counts, they have gone up to even 458,000 and above. Cross the range also. Is there any reason? Is there hyperproduction? What happens, or how does the body system work? It's an amazing thing. So people doubt the reports because yesterday it was like 50,000. Today you are saying it's 4 lakhs or something. How does this explain that?
Okay, let us take two situations here where you have got a thrombocytopenia on the initial day. The next day you see that you have a normal count.
Yeah.
And after the next day you see a low count. And again you have a hyper count on the next day, that is a 48 hours. Now this moves ups and down of this is based upon two things. One is your body response to that of the low platelet count from the marrow itself. So from the marrow, you might be having a hyperplasia because of an rampant destruction of the platelets. There is a hyperplasia itself. The second point would be that if the patient is having hypersteroids, which are increased at that time, that is when there is an increased steroid secretion in your body because of the stress, because of your mental stress or increased adrenaline, the platelet count increases. So we should understand that there is a bit of synchrony with our hormones, which might push the platelet count up and down. And we should rely more on what is called as the presence of the giant platelets on your peripheral smear, or if the machines are able to give you platelet distribution width, that is called as the PTW, which says that the PTW is high, the platelets are macro. If you have got macro platelets, the bone marrow is hyperplastic. So that's why it becomes mandate that when you have a question from the clinician like that, we can tell him that, doctor, we can have the PTW share for the previous day and now. On the peripheral smear, I have seen giant platelets, and this is definitely the right value what we have given.
Yeah, so what I was going to say is that the PTW and all the parameters are really, nobody looks at them, We just leave it off, though it can give a lot of useful information also. And this question was for all I asked on behalf of all the clinicians who obviously don't know what's happening, in such cases when the counts really go up beyond. Another thing is, how often should you repeat the counts? So, in dengue cases and things, people repeat the count almost every day. Do you think that's required? Or what would you think about it?
So I feel that in cases like hepatitis, whenever you have got a low platelet count because of infectious etiology of malaria, dengue, or leptospirosis, we have to monitor the platelet count at least for about 24 hours. So if you have done night, in the morning, there is no need to do until unless you have done some transfusion or what you call management of the case itself. But of course, if clinically they are finding out that this patient is having hematuриas, epistaxis, then they have to definitely evaluate for the platelet count. By default, we can say that you can evaluate the platelet counts exactly 24 hours for at least 5 days in a week. And later on, you can convert that into weekly ones.
Thank you so much. This was for, on behalf of all my clinician friends and us also.
Yeah, thank you so much.
Thank you, Dr. Anita, for bringing out all these points so lucidly. And thank you, Dr. Srinivas, for your answers. Thank you very much for taking time off from your busy schedule to participate in Marvelous Medicine. And special thanks to both of you for such great synchrony and bringing out so many useful points for both laboratory science students and practitioners as well as clinicians. We hope to see you again in some other session in the coming weeks or months. We'll meet again next week with another episode of Marvelous Medicine. Till then, take care and stay safe. Good night.
Good night, ma'am. Thank you so much. I have only one request, ma'am. If these videos are ready, you can just post it so that we can put it across the social medias as well as to our groups, ma'am.
Absolutely. Radhakrishna will share the YouTube link as soon as he uploads the edited video onto Learning General Surgery YouTube channel. All the Marvelous Medicine lectures are there, but we will specifically share them with you so that you can share it among your groups as well. And like Radhakrishna said, I think every student of medicine and every practicing clinician should watch this to get, I'm sure everyone will learn at least 2 or 3 new things that they never knew about. So thank you again for this very illuminating session. Good night.
Good night, ma'am. Thank you.
Good night.
Thank you, Anita, Dr. Radhakrishna, and Dr. Vidya. Thank you, all the delegates. Thank you.